Well, hello everybody. My name is Peter Werwine and I am Senior Editor of Managed Healthcare Executive. And this afternoon, in sort of the dimming light of late fall, I'm speaking to Dr. Philip Adamson, excuse me. He is Chief Medical Officer at Abbott, and he has responsibility for the global development of Abbott's heart failure program. So thanks for taking time to talk to me today.
My pleasure, Peter. Thanks for having me.
And sorry for garbling your name.
No worries.
First try there.
It's commonly done. No worries.
So I'd like to just talk to you at the beginning about the relationship of COVID-19 infection to cardiovascular disease. Of course, this is a virus that enters people's bodies through the lungs. As we know, it binds to ACE2 receptors, and that created issues about whether people should stop taking their ACE inhibitors or not. But we think of it as a lung infection, but I think it's, as experience has shown, as the numbers have accumulated, we see that it actually has profound effects on the cardiovascular system. So I was wondering if you could tell us what your understanding is of why this infection is turning to be, in some respects, a cardiovascular event.
Well, Peter, that's a very important question because the cardiovascular manifestations of the COVID-19, especially moderate to severe disease, can be quite devastating and lead many times to the advanced therapies that are required in intensive care units and the prolonged lengths of stay, as well as the comorbidities that develop post-COVID infection. The angiotensin receptors are located in every tissue of the body, including the heart, and they allow the viruses, just like any other virus, to enter all the cells in the body, including the heart cells. So the battle, essentially, of the immune system fighting this aggressive virus occurs throughout all the tissues of the body. The systemic inflammation, or the inflammation that occurs all over the body, damages pretty much all the organs. The heart being one of them, and can be quite profound in terms of the inflammation, the damage to the heart muscle, the damage to the blood vessels, the damage to the coagulation pathways that lead to blood clots formation, and all of those give rise to cardiovascular complications.
So should we think of it as the disease-driving event as being thrombosis and the development of blood clots, or is it an insult to the actual cardiovascular tissue, and maybe heart tissue in particular? To get ready for this interview, I stumbled on a JAMA Cardiology paper out of Germany, where I think MRIs of people's hearts, you're probably familiar with this paper, something like 60% of recovering COVID-19 patients, there was some indication of myocarditis, inflammation of heart tissue. So do you see it as a thrombotic event, or is it something that's affecting the heart tissue directly, or is it sort of an all of the above?
It's really both, I think. I think that the microvascular thrombosis that occurs, even when this profound procoagulable state is not clinically present, seems to not only impact the lungs with thrombotic complications, but also the heart. So I think there are microvascular, of course we know there are macrovascular events, such as young people having in situ thrombosis just developing in the proximal coronary vessels, causing a classic acute myocardial infarction. But the microvasculature is suspect to, or is susceptible to complications from this illness. And I think it is this coagulopathy that develops. I think that's part of it. And that's probably on a spectrum of sort of subclinical damage that occurs both to the lungs and the heart, and it can become quite fulminant, such that all the blood vessels of the body are clotting. Deep vein thrombosis, pulmonary embolism, cerebrovascular accident, myocardial infarction, all of that has been described with the severe cases of COVID-19 as a result directly of the viral infection. And then there are the complications associated with the direct infection of the virus, which I believe are the ones that you've referenced, mostly come from the immune response as well as the inflammatory response that ensues after this infection becomes moderate to severe.
So I think doctors, the healthcare system, are becoming better at treating COVID-19 patients. We have some therapies now, some of them still experimental, but we have, the antiviral medicine, remdesivir. So if we are able to treat people earlier in the course of disease, and therefore there's fewer people with these strong inflammatory events occurring as a result of the infection, would you expect to see a tapering off of cardiovascular disease and events that are the result of COVID-19?
I think one of the things I've learned, having studied this disease and worked with people from around the world who are in contact with it daily, it's been a very humbling experience, and it's hard to predict. And so I would hope so. I would hope we'd see less organ involvement, less damage to the heart, to the lungs. But quite frankly, Peter, it's difficult for me to know what's going to happen in 2 years to the people who have survived a moderate to severe case of COVID-19. We don't know. We've only been in this for less than a year. So in 2 years, will we see a pandemic of dilated cardiomyopathies as a result of this process that has sensitized the heart to a chronic slow burn immune damage that could be a long-term sequela of this? We don't know. And so I certainly hope that early intervention will prevent the sequela. It's interesting, if you look at athletes who have been diagnosed as COVID positive, even when they don't have overt clinical disease, tend to have enhanced gadolinium scans to suggest that there is some residual scarring in the heart. And it's become a real conundrum as to what kinds of risk do they have when they return to high level participation in their sport. So we still have a lot to learn, to be honest. And I think that, thank goodness, we're seeing promising therapies. And I would hope that the therapies, especially when applied early in the syndrome, would mitigate, if not reduce significantly, the particular cardiovascular complications that are associated with this disease.
Your mention of athletes is a sobering reminder to me how serious this disease is, when the most robust among us maybe will suffer long-term consequences. So it's as you say, it's a sobering disease, and I think one that's going to be with us for a time. So your work with Abbott is in the area of heart failure. So how do you view, what are you looking at in terms of COVID-19 and heart failure? Are you seeing people with pre-existing heart failure being more susceptible to the infection, or if they get the infection, are they more likely to suffer a severe consequence? How's this playing out in heart failure?
Well, it's an interesting phenomenon, and I chuckle because every time we think we know what it should be, it isn't. We thought, of course, that patients with advanced heart failure would be at very high risk for immediate death once they developed COVID-19, but that's not necessarily the case. We've seen patients with heart failure decrease their need for hospitalizations, and maybe that's because they're afraid of being exposed to the virus and they're taking very good care of themselves and not having exacerbations needing to go to the hospital. On the flip side, we see places like Bergamo, Italy, or even in New York, a 300-400% increase in the number of deaths at home that are ascribed to cardiovascular disease that were directly related to the avoidance of medical care in the throes of an acute illness. And so it's a mixed bag, but what we see emerging, I think, from the data that is global as well as regional, is that patients with metabolic syndrome, which is typically obesity, hypertension, and diabetes, which we would call stage A heart failure, at very high risk for heart failure in general, are the ones that are at the highest risk for the inflammatory process that can cause a moderate to severe disease. And if you think about those disease syndromes, they are characterized by an underlying inflammatory state in the beginning. And so when you have this disease that comes and then superpowers the inflammatory pathways, it makes somewhat sense that those are patients that wind up in the intensive care unit on extracorporeal membrane oxygenation, intubated, and all the things that go with complete lung and cardiovascular collapse.
Yeah, inflammation often seems to be sort of a shared pathology for many diseases, metabolic syndrome and others, of course. So if this population with metabolic syndrome, which of course is a huge population in this country,
right,
is particularly vulnerable, then what does that say about what we should be doing to attend to those people's healthcare needs, perhaps with some special focus? Do they need to be monitored remotely? Do programs to make sure that they take their meds as prescribed, that they have access to their medications, that cost isn't a barrier, convenience isn't a barrier? Is this something that the healthcare system should be coalescing around, this population?
It appears that that's exactly the truth. And gosh, if we think about it, 17 or so years ago, the American Heart Association, American College of Cardiology came to a consensus to identify people with metabolic syndrome as sort of a pre-heart failure state because of the very high risk that in their lifetime they would develop heart failure in general, and gave compelling reasons to control their blood pressure with medications that also are effective for people who have heart failure, to control their cholesterol, to keep them, hopefully decrease their risks for coronary artery disease that leads to heart failure, and to increase their activities and decrease their weight, and all the things that we've had as sort of the healthy societal efforts that the American Heart Association has been doing for many, many years now. Unfortunately, there's still a lot of people, as you mentioned, that suffer with this syndrome and maybe don't even recognize that they have a syndrome. And it is insidious, and it is one that unfortunately, especially in special populations like African Americans, leads to very early dilated cardiomyopathies, heart failure, and death. And that disparity of gosh, if we could just treat their high blood pressure. And you think about that, we learned that in the 1970s. And so in 2020, how is it that we're still saying if we treated high blood pressure, we prevent heart failure? And we seem not to kind of get it. And so, yes, I think there is an underlying need to focus on the highest risk populations, even outside of the COVID-19 pandemic, to address some of these disparities, both from a medical equality perspective, but also from an effectiveness perspective.